We're going to try to make this exciting. I don't know. But remember that chronic kidney disease is the new term, just like with the other acute kidney injury. This used to be called chronic renal failure, but this is the newest term. Your textbook, I think, is up to date with this new term, but not up to date with the other one. So just realize that if you see the word chronic renal failure, they are talking about chronic kidney disease and liver. Same thing, new term. Acute kidney injury happens more acutely. It happens fast with an acute illness or something like that usually. But chronic kidney disease is progressive. It's a progressive decline of kidney function over a period of time. And usually it's due to something else, another disease that is causing chronic kidney disease. Older men are at greater risk for having chronic kidney disease, and minorities are also at higher risk because minorities generally have those diseases at higher rates that are attached to chronic kidney disease or that cause chronic kidney disease. To get a diagnosis of this, the GFR should be less than 60 for 3 or more months. At that time, maybe they're evaluating chronic renal insufficiency, or maybe it was acute kidney injury and it's going to progress to chronic renal disease. Acute kidney injury can progress to chronic kidney disease. So these are your top 4 causes that lead to chronic kidney disease. And this is kind of the patho of each one and how it causes damage to the kidney in causing this renal problem. So diabetic nephropathy is by far the #1 cause of chronic kidney disease. And the glucose damages the glomerulus and causes nephron destruction. So therefore, GFR is not going to happen because of the damage to the kidney due to diabetes. Diabetes is obviously a big problem in America, so chronic kidney disease is rising due to this mostly. So hypertension is also another cause of this. So just because of the increased pressure and also hypertension is often comorbid with arteriosclerosis, so therefore the renal arteries become stenosed and sclerosed. And therefore, it reduces the blood flow to the kidneys and causes ischemia and atrophy of the nephrons, leading to chronic kidney disease. Glomerulonephritis, which you're familiar with, which is connected to strep, and so this is caused from the inflammation due to that infection, and the tubules and capillaries in that nephron become damaged and obstructed, leading to loss of function. Like those nephrons again. Cystic kidney disease, you may hear this referred to as polycystic kidney disease, same thing. But the cyst, remember a cyst is like a pocket of fluid or something, and these pockets are compressing the tissue of the kidney. Therefore, it decreases the perfusion, inflammation, destruction of the nephrons. All right, so understand the physiology of how these diseases lead to chronic kidney disease is pretty important. They all end up causing the same thing, but the way that it happens, you should understand the difference. This is from your book, so you can see that the vast majority of chronic kidney disease is caused by diabetes. And they're in order: hypertension, glomerulonephritis, and polycystic kidney disease. All right. I got kind of happy with pictures in this slide. That's what happens when I'm sitting at the mirror, hitting my head. In these slides. I go through it too. I'm not the only one sitting at coffee shops and restaurants studying. So, you're not the only one. So here's what polycystic kidney disease looks like. So this is a normal kidney. So you see these pockets, these cysts, and you see how this kidney is also enlarged because of those cysts, and those cysts cause compression again of that tissue, leading to hypoperfusion of the kidney tissue. This is hypertension, so it's hard to see here, but you can kind of see how the pressure in the vasculature is causing damage to the walls here of in the glomerulus. So therefore, and also thrombus can form. So if the thrombus is there, it's kind of like arteriosclerosis, decreasing perfusion in the kidney and the renal arteries also. Well, under this right here, it shows how the glomerulus here inside the capsule is damaged due to the diabetes, and the protein can easily leak out, and that protein there should not be protein in the urine. So when a person has diabetes, they're going to have a checkup at their primary care endocrinologist every 3 or 4 months, right? So in at least once to twice a year, they're going to measure that person's microalbumin. Does that sound familiar? No? Well, write it down. So a person who has diabetes is frequently monitored their urine for microalbumin. So if they have microalbumin in the kidney or in the urine, that tells us that the diabetes is damaging the kidney. All right? So we would not want a person to have microalbumin in their urine. I couldn't find a picture of the kidney with glomerulonephritis, but this is one of those pictures, that I like. So remember the glomerulonephritis.
Control yourself, ladies.
Remember the signs and symptoms of glomerulonephritis and what it's caused from, and how we can prevent it. All right. I'm not sure why they put this person on a porta potty. I don't know. I'm not really sure.
Especially
because you have oliguria, so he wouldn't be peeing very much. But anyhow, so I guess you would. With his little swollen face there. But anyhow, that's that. I thought these pictures were pretty nice. So, we talked about the patho of how the diseases that are most linked to chronic kidney disease lead to chronic kidney disease. So we'll just go through this. I know that's a bunch of words, and I'll try to talk through it without just reading it to you. But because of the chronic disease that you talked about, diabetes and those things, cause the glomerulosclerosis, damage to the nephron. But the key here is that the nephrons that are still healthy, that are not damaged yet, will take over. They will compensate for the ones that are damaged. So what happens here is those nephrons that are still working are hyperfiltered, and that causes increased capillary pressure in the glomerulus. So again, hypertension, all right? So when you have increased pressure in the glomerulus, it leads to further destruction of those healthy nephrons. Okay? So it's kind of like the body's compensating, but eventually that's not going to work, Not until the GFR gets to about half does the BUN and creatinine rise. So that's kind of concerning. Half of your kidney function is gone, and now we have labs that tell you so. So the key here is what? Managing chronic diseases, especially hypertension and diabetes. And at about that 50% loss, the creatinine will get up to about the double, right? So, if their baseline is 1, you would expect to see about a 2 with the GFR of 50%. So just to go from 1 to 2 is not a big jump, So there's that creatinine is a tight little normal range, 0.6 to 1.2. All right? And here my example is 0.6 to 1.2, whatever. But it doubles. Does that make sense? The hyperfiltration, the compensation for those healthy nephrons. This is just memorization. I just took this table directly from your book on page 850. So you need to know the difference in the stages of kidney disease. And the stage of the disease is determined by the GFR. The last stage of chronic kidney disease is end-stage renal disease. Some will call this end-stage kidney disease, same thing. So it's where the kidneys are barely working. So this is the last and worst stage of chronic kidney disease. So we talked about most of this already with acute kidney injury. But again, the urine, often the urine-specific gravity will be fixed because the kidneys will not have the ability to concentrate urine. You might find protein, blood, casts in the urine. All those things do not belong in the urine. let's see. So again, creatinine is the most specific indicator. BUN, of course, is measured with it, but BUN can rise for other reasons. I talked a little bit about how the GFR is calculated, but again, it's based on the age of the person, the race, and the sex of the person, and it's compared to the creatinine. And just as a baseline, African Americans usually have a higher GFR. It's just what it is. African Americans usually have a higher baseline GFR. I don't know why, but all right. So also measuring electrolytes. So also with chronic kidney disease, like acute kidney injury, we have the problem, mostly of these electrolytes. So high potassium, right? Low calcium, high phosphorus, right? Metabolic acidosis, because the body is unable to clear that acidic content, the hydrogen. Anemia comes along because of I mentioned this also, the erythropoietin is not produced by the kidneys because they are damaged. So the bone marrow doesn't produce red blood cells as it should, not meaning that the bone marrow has lost the ability to do so, but the kidneys are not giving it the instruction to do that. Vitamin D we would expect to see low, and parathyroid hormone would probably be high, because secondary hyperparathyroidism is a complication of chronic kidney disease. The ultrasound tells us about the size of the kidneys, and if polycystic kidney disease was a problem here, we would see an enlarged kidney. But often we see atrophy of the kidney in chronic kidney disease. To differentiate between the two, acute kidney and chronic kidney is a biopsy. So I mentioned that there's 5 stages of chronic kidney, and during stages 1 through 3, there's usually not a lot of manifestations. So this is when the person has diabetes, they can't get their A1C under control, or their hypertension is under control for years. Renal function still looks good, but during that time, the person's kidneys are being damaged, though they're not showing any manifestations. So remember, the patient's creatinine is not going to rise until, stage 3 or so. So symptoms usually develop when the GFR falls below 30. So only 30%, right? So that's not good. Because normal GFR is about 100, right? So you compare to, so we've got about 30% function. The term uremia technically means urine in the blood. But this is a vast group of symptoms, syndromes that are related to chronic kidney disease, especially end-stage renal. In general, this is how you're going to think about this. These are a few examples of early signs, and then these are more examples of later signs. But I'm going to go through many slides that describe all of the manifestations of chronic kidney disease based on the system. So the uremia causes body-wide manifestations. So let's talk about fluid and electrolyte manifestations. Early, the person may be dehydrated. Maybe if the insult was caused from an acute kidney injury, right? That they could be dehydrated from that because they maybe were in the diuretic period. But generally, we think about a person who is in end-stage renal disease or later stages of chronic kidney are going to have fluid volume overload, of course, right? Because they can't excrete it. They can't get rid of the volume. So they have water and sodium retention. So we would have to teach that person to be on sodium or salt and fluid restrictions. And I'll talk more specifically about that. Generally, hyperkalemia is not severe until the person has reached stage 5 of chronic kidney. Remember that calcium and phosphate are opposite. The person would have high phosphate and low calcium. Remember, we have to have vitamin D in order to use calcium appropriately. Magnesium high, and of course, the metabolic acidosis. So you guys are probably really good at this, but know those signs and symptoms of your electrolyte disturbances. You might have to brush up on magnesium.
I looked that up, and it said that there weren't really any signs and symptoms. It was often asymptomatic.
Yeah. And one thing about magnesium, when you have an alteration in magnesium, it throws everything else off. It's kind of like the mainstay of all of your electrolytes. It kind of holds everything together. So I've talked with my clinical people about this, but when you have to give some electrolyte replacements, I mean, sometimes you get tons of orders. You've got to give magnesium, you've got to give calcium, you've got to give KCl, you've got to give sodium phosphate, all of them. Which one do I do first? Always give magnesium first. All right, because if you get it corrected first, the other electrolytes will come into balance much easier. Cardiovascular manifestations, like I said, this big cause of death when the person reaches end-stage renal disease. The person is usually not going to die from renal disease. They're going to die from complications, right? But because of the excess fluid volume, the activation of the renin-angiotensin system, which leads to angiotensin causing these cardiovascular issues, and the vasoconstriction would lead to increased peripheral vascular resistance, right? So realize that the increased circulating volume leads to high blood pressure, right? And also that can lead to heart failure and pulmonary edema. Arteriosclerosis is accelerated. The person with chronic kidney often has hyperlipidemia. So this person almost always will be on a statin. They're also at risk for pericarditis. Didn't we talk about that before? A long time ago. Yeah. But the inflammation here is caused by those retained toxins that are in the blood, inflaming the pericardium. And glucose, of course. Again, I've mentioned this a couple of times, but it's really important to understand this process of how chronic kidney leads to anemia. So decreased erythropoietin. But the toxins also suppress the production of red blood cells and the lifespan of the red blood cells. So the red blood cells that do get produced from the small amount of erythropoietin that is around are not very good red blood cells. So this person is chronically anemic. Also, folic acid and vitamin B12 are frequent deficiencies in chronic kidney. The person also is at risk for lots of GI complications, increasing the risk of GI bleeding, so increasing the risk of further anemia due to GI bleeding related to this. So when you're anemic, those signs and symptoms are what? Impaired cognition, weakness, fatigue. So that person's baseline symptoms from your anemia that cause these things are going to be exacerbated by even more by anemia. And of course, if you're anemic, you're going to have an impaired cardiovascular function, impaired oxygenation. The platelets also, are produced by the bone marrow, and during your uremia, the platelets are not very quality, not high quality. Just to understand the physiology of what happens here. So it's kind of a feedback mechanism. So when the kidneys sense that we have a low hemoglobin, we don't have enough circulating oxygen, the kidneys produce more erythropoietin. We don't have enough oxygen being delivered with this hemoglobin. So what happens is it produces more erythropoietin, stimulates the bone marrow to produce more red blood cells. And this is just that little process of the formation of red blood cells. You do not have to memorize that. But I thought that it was a neat little picture. And the next picture I put on here because I thought that was funny. So this guy has normal oxygen, normal red blood cells. He's very happy. And this guy doesn't have a lot of red blood cells, and he's hypoxic, so he is not happy. So I thought that it was a funny picture. So that's why I put it on there. I was Googling for this one, and I found that. I was like, that's funny. So I'll put that on there. But I guess I wouldn't be happy either if I didn't have enough circulating oxygen. So, but I thought that it was a fun picture. So the immune system is affected as well. The white blood cells are suppressed. The function of them are not good, and the number of them are low. The person's not going to develop a fever properly, which of course is an immune response. Fever has a good purpose. But the person who is in chronic renal is not going to produce a fever as easily. GI complications. I hate reading this to you, but anorexia, so you know that's a decreased appetite, and that's just a direct effect of uremia. This is the right, it's not HICCUPS, it's hiccups, right? That's the correct term, spelling for hiccups. So it's just a weird phenomenon that people have hiccups. That's peptic ulcer disease, and you know about that when we learned about, I think, endocrine things. So remember those signs and symptoms, how to identify that. This is interesting, uremic fever. And uremic fever is basically a urine smell to the breath. It doesn't sound too good, right? But it's the smell of urea. Also it produces a metallic taste in the mouth, so this increases the patient's risk for decreased appetite. So if you have altered taste, you're probably not going to want to eat all that. So,
Why am I thinking fruit smell?
that's what DKA is.
Okay.
Yeah. And that's the ketone. Just in general, think about obtunded mental status as a manifestation of this. And there's a uremic encephalopathy syndrome, which can lead to serious complications, seizures and coma. You guys remember what peripheral neuropathy is? Tingling and burning in the extremities, restless leg, weakness. So you can just think about everything is pretty much suppressed here, the neurological function.
Mr. Sasser?
Yes, ma'am.
Is the peripheral neuropathy like a human blood or a sac blood?
I'm not familiar with that term, but
Or
often it's
just your hands and feet?
often it's the hands and feet. Yeah. So because of the hypocalcemia, we have an increased parathyroid hormone secretion, and we call this secondary hyperparathyroidism. This is basically the physiology or patho of hyperparathyroidism. But just realize that this person has an increased risk of fractures, osteoporosis, decreased bone mass because of this. Oh, well, diminished deep tendon reflex. No reflexes.
Does that have something to do with the magnesium level? Is
The
that something that has to
tendon
do
reflex?
Yeah.
Possibly, but I think that another thing that comes along is I think it's calcium also that causes changes in reflexes. But they're both low. Or actually high magnesium. But that's good. Yeah, endocrine disturbances. So though this person may have developed chronic kidney disease because they had diabetes, well, just having, even if they don't have diabetes, there's glucose intolerance, insulin resistance, even with this. So the person already has diabetes, it's like a double whammy. Uric acid, is normal in the blood, and in the urine, and the kidneys normally excrete it. But when there's increased circulating uric acid, it puts a patient at risk for gout. So remember, the gout often is manifested by what? Pain usually in the big toe. That's by far the most common place that it starts. But it can really happen with the hands, the feet, legs. And I told you also that this person will also have dyslipidemia or hyperlipidemia, almost always on a stat. Changes in menstrual cycles, and then low testosterone, which leads to impotence and low sperm counts in men. pretty bad, right? There's a lot of skin issues that come along with this. So the skin color is different, maybe a yellowish hue or paleness because of the anemia and the inability to excrete these metabolites that are deposited in the skin and cause darkening of the skin. Dry skin, and so that leads to poor skin turgor, dehydration, if that's an issue, can lead to this, and sweat glands are not so abundant. Bruising, so that could be caused by what? The impaired function of platelets, right? And then, the skin often in this situation will excrete some of the toxins that the kidneys aren't able to do to excrete. So it leads to a lot of these manifestations, but lots of itching, and also that's related to uremic frost, which is quite interesting. It's urea. It has made its way into the sweat, and then the body's trying to get rid of the urea through the sweat. So it looks like just, it almost looks like just dry skin, severe dry skin, but they call it uremic frost, and it's just urea on the skin. I would say that wouldn't smell good. So lots of skin care. There's a high rate of depression in a person who has renal disease, especially end-stage renal disease, or if the person is on dialysis, high rates of depression. So we certainly need to screen for that and report any signs that we see. That didn't take too long. It's nice and exciting. One of the big nutritional things that we teach our patients who have chronic kidney is to avoid protein or have a low protein diet. Just remember that all of our bodies can't store excess protein. So if we take in a large amount of protein, what our body can't use at that moment is excreted. We get rid of it. But the person with chronic kidney cannot do this. So these byproducts of protein, the hydrogen and phosphates and nitrogen is going to hang around. So that's why the person should have a lower protein diet. But not until stages 4 to 5 should this be a serious recommendation. Because when a person has a protein restriction, there is for malnutrition. So you want to make sure that the person is getting enough protein early in the disease so that combats or prevents malnutrition. So when we do teach our patients about a protein restriction, you can think of it in a couple of ways. 0.6 grams per kilogram per day, which is very specific, or just for the average adult, no more than 40 grams per day. And I just thought about my favorite steak as a filet. And just a small 8-ounce filet is almost 60 grams of protein. So, just one steak. That's too much for them all day long. So, just keep that in mind. All right? So, just so that you can have a comparison. And I think that they say, what is it, any nutritionist in here, I think it's something like no meal should contain more than 30 grams of protein for anybody. That's about all you can handle at one time. Does that sound right? So yeah. And so therefore, that nice filet that we eat, we're only getting about half of it anyway. So the protein, but all the calories. But I think, lean meats are not extremely high in calories, if it's lean. And fillets are pretty lean. And the protein that the patient is eating should be of high quality. And I mentioned this yesterday or Tuesday. And these are some examples of high quality or high biologic value protein. Fish can be a good choice, but some fishes are high in phosphorus, which should be avoided. So fish is good, but not if it's high in phosphorus. Chicken breasts, so lean meats are okay in small quantities. It says low cholesterol egg product. I tried to figure out what that really means, but I think it just means egg whites.
It's liquid eggs.
Yeah, liquid eggs. Yeah. But also eggs can be high in phosphorus too, so they should be. It's a tricky situation here. But soy also is good quality protein. But like I said, small amounts of meats, 6 ounces per day should be the maximum. I don't know how that would convert to grams. Can't do that. But, let's see. Also, foods that are high fat should be avoided. The person has hyperlipidemia, probably, right? And phosphorus is high in a person with chronic kidney, so it should be avoided. Milk products, these are things that are high in phosphorus. I think I put some more things somewhere else too. Carbohydrates, so normally we think about energy with protein, and it's a good quality energy, but they can't have a lot of protein when they're in end-stage renal. So we need to increase the amount of carbohydrate intake for a person with chronic kidney so that they have energy for metabolism. But then you get into that sticky situation when this person is diabetic, right? So it's a very, very tedious process with this person's diet. And we're going to educate in general about things, but this person will have a referral to a dietitian. The sodium restriction helps maintain blood volume so that it decreases the risk of hypervolemia, fluid volume overload. 2 grams per day should be the maximum. High sodium intake, hypervolemia, along with diabetes, is not a good combination. Big problems with that. Remember, the fluid restriction is 1 to 2 liters per day. That is not a lot of fluid, right? So if you just wanted to try it one day, see if you could restrict yourself to 2 liters, it would be difficult. So it seems like a lot of volume, 2-liter drink, but it's really not. So realize that is a big challenge for people who are on fluid restrictions.
The fluid restrictions are also including the fluid that's in food?
No, fluid restriction, yeah. So drinks, basically, yeah. Because you're right, there's a lot of water in food. We get a lot of water from food, but it's fluid restriction, so drinks. In acute kidney, the potassium restriction is a bit stricter, more strict than this, but just running with chronic, no more than 60 milliequivalents per day. So you might, teach a person to avoid table salt, well then maybe the first thing they'll pop in their mind is, I'll use artificial or substitutes for table salt. Well, they can't because that has a lot of potassium in it.
Maybe on iodine supplement or something.
I don't think so. But yeah, where are they getting their iodine? But they can have fish, certain types of fish. So blood pressure should be a high priority to keep it under control in a person with chronic kidney because of the risk of the increased pressure in the vasculature causing damage to the nephron. So the person with chronic kidney should have a blood pressure of less than 130/80. This is also the goal of a person with diabetes. And you just have to remember, when in general, when a person has hypertension, no other big issues, no diabetes, no kidney disease, less than 140/80 less than 140/90 should be their goal. And I don't know why we say it like that, but just remember when you see 130/80, that means 120s/70s, right? So 130/80 is the max, that's the limit. So this person should be 120s/70s. So I wouldn't be happy with a person who had a blood pressure of 130/80. I said it needs to be low. And then you say, a good optimal blood pressure for the average person without disease should be 120/80, right? Well, what that means is 110s/70s, less than 120 over 80. So if your blood pressure is 126 over 85, you're pretty hypertensive. So just keep that in mind when you're teaching your patients. Don't lead them to believe that 130 is perfect. It's not. It's the limit of what we want. So 125 over 70 would be perfect. All right? Just remember that when you're teaching. I keep mentioning this, but treatment for hyperlipidemia is a big goal. The person who has a problem with their A1C, with their glucose, diabetes, or whatnot, should have an A1C of less than 7. That's hard to reach. It's really a difficult goal to reach. Often, many times I've seen patients in clinics when their A1C is 10, 11, 12. It happens all the time. It's very hard to get to an A1C of 7. I think that an A1C of 7 equates to a blood glucose average of about 120 or so. So we want this person to have pretty much a normal glucose at all times. So. Again, this secondary hyperparathyroidism, so we want to give them some D3. And you remember Sensipar? And so that's a good choice in a person with chronic kidney that has a secondary parathyroid problem. So it increases the parathyroid gland's sensitivity to calcium. This person has low calcium, right? These medications are examples of phosphate binders. I've seen some references that refer to these as phosphate scavengers. I like that term better, but I think it's neat. But phosphate binders is the term that we'll use. And how these work is basically by binding to phosphorus during a meal, the contents of the stomach and intestines, so that the phosphorus is not absorbed into the system, and then it is excreted in the feces. Anytime that you're taking a medication to lower phosphate and to increase calcium, you're going to have the risk of hypercalcemia, right? That's just with anything like that. Lots of GI complications or side effects. Just think of where it's working in the GI tract. So that's where your side effects are going to come from. And these medications should be taken with food, or they don't work. Right? Take it with food so that it attaches to the phosphorus in the meal so that it is not absorbed. It's not absorbed systemically and then works that way. It works in the gut. So it has to be taken with food. To treat the anemia, we do a couple of things. Procred or Epogen is a medication that is given to increase erythropoiesis. Basically, this is synthetic erythropoietin. It's given either IV or IM, and it's not indicated until the hemoglobin falls below 10. I said it's not a blood product so that you know for your cultural issues with Jehovah's Witnesses it is acceptable that they take Procred. So fever, the hypertension could be related to the increased production of red blood cells. Volume in the blood could lead to hypertension, and headache. Nausea, vomiting also is a complication side effect. It can get very pricey. Often our patients need high doses of Procred for it to be therapeutic. And when we get into those high doses, it can be up to $1,000 per dose. So just keep in mind how expensive it is. When you give it in the hospital or wherever you work, probably what will happen is the pharmacy tech will have to hand deliver it to you, and you sign for it because it can't get lost in the tube station. It's just too expensive. All right. Also, the person's iron levels, ferritin, will be monitored frequently for anemia, and if that is a problem, they will have, probably low iron, so they will need to have ferrous sulfate for supplementation for iron, low iron. Remember that ferrous sulfate is taken with meals, usually 3 times per day. Lots of GI side effects, right? patient is on iron daily and have a bowel movement and it's dark and tarry, don't freak out, okay? Don't think that it's a GI bleed. It's just the iron, most likely, all right? The metabolic acidosis is not always treated. It's treated only when it becomes severe. You know, I think that when the pH reaches 7.1, then they're going to really treat aggressively. This person will be chronically acidotic, so they can withstand that. But not until the metabolic acidosis becomes very severe will they treat it with sodium bicarb. Remember, sodium bicarb is not a. It works, but it's not a permanent fix for anything. It's always a quick fix. But if the person gets to the point of needing sodium bicarbonate and the severe metabolic acidosis, they need dialysis. So that would fix the metabolic acidosis. But also, it can help prevent the complication of peptic ulcer disease. You know, bicarb is obviously a base, so it will decrease the acidity of the stomach and increase the pH. Remember, increased pH means decreased acidity, right? Mouth care for uremic feeder and the person who has peptic ulcer disease will likely be on a proton pump inhibitor, right? You know all about those. What? It's a lot in it. So, all right. So other treatments are we call these things renal replacement therapy. So basically dialysis. There's hemodialysis, which is the filtering of the blood. Peritoneal dialysis is using the peritoneum as a semipermeable membrane to filter. And also we can have continuous renal replacement therapy, which is a type of hemodialysis, but it's slower and continuous and generally happens in an ICU. The person with end-stage renal hopefully will be on the transplant list. This person will be monitored very closely by a nephrologist, a dietitian, and maybe a surgeon if they do need dialysis and they need to have vascular access placed. There are studies that show that the person with chronic kidney has an increased risk of obstructive sleep apnea. So we need to closely monitor for that as well. Ask how the patient is sleeping and things like that. All right? So increased risk of obstructive sleep apnea as the GFR falls. And this person will be to see their primary care provider at least, every 3 months. These are some priority nursing diagnoses. This says risk for ineffective renal perfusion, but also the person may have ineffective renal perfusion, right? Obviously, if they have this chronic problem. But it relates to the nephron destruction and the arteriosclerosis of the renal arteries, and we're going to see fluid and electrolyte imbalances that would let us know that this is happening. All the dietary restrictions, the manifestations like uremic feeder, decreased appetite is going to lead this person to malnutrition, right? Less than water requirements. And they're at big risk for infection. Often, or not, I wouldn't say often, but when the person receives a renal transplant, they would be on immunosuppressant therapies for a lifetime. The invasive procedures that are involved with dialysis and things like that, and also the white blood cell dysfunction due to alterations of the production of white blood cells during this. So that leads us to a big risk for infection. Read this question. What about D? What about A? Nobody in B? C? Somebody thinks it's D. Good. I thought it'd be a hard question.
We're just too smart.
You're just too smart. Yeah.
C or D?
D.
D.
And I think it's A. B. C. C. Good. Those are just too easy, aren't they? Maybe it should just be the generic name.
I just read both, the generic and the drug name.
What about A? No? B? Yeah, some B's. C? D? Brooke doesn't see a right answer.
That's why
Is anybody unable? Does anybody not see a right answer? Read the question again. The patient needs further teaching when? Yeah, it's B, right? Because they're stage 2. Right? I wrote this one. Right.
But isn't that a good idea anyway? People eat too much protein. Isn't that, I mean,
Well, we wouldn't tell them to eat excessive protein, normal intake of protein. Yeah. It should be restricted until later stages.
okay, got it.
Yep, 3 to 4. I'm trying to think. I think we can get through dialysis therapies. I'm just thinking. Next time, can we? I think we can do dialysis. Well, I mean, I can just continue on, I guess.
It would be integrity, and you could get us the slides, and then we could.
I think I can get through it all in an hour. I've gotten good at speeding it all. No. Next time, because remember, next time Maxine will be here at 2. Right.
You can do it.
So, next time, read about hemodialysis, peritoneal dialysis, continuous renal replacement therapy, renal transplant, complications of that, renal rejection, all of that, and maybe a couple slides on renal tumors. But
When are you going to post those slides?
probably over the weekend. Any questions?